Hello, everyone, and welcome to today's industry webinar, New and Expanded Flexibilities for RHCs and FQHCs during the COVID-19 pandemic. My name is Ellen Knowles. I am the Marketing Communications Manager here at Azalea Health, and I will serve as your moderator for today's presentation. Before we get started, I'd like to go over a few items so you know how to participate in today's event. All attendees are in listen-only mode, and know that the system defaults to your computer audio. If you would prefer to join over the phone, just select telephone in the audio pane on the right-hand side of your screen, and the dial-in information will be displayed there. You will have the opportunity to submit questions during the webinar. We will address them at the end of the presentation, and we would love to have a very interactive Q&A session, so we really encourage everyone to send in your questions at any time. Also, please keep in mind that there are new updates being released very frequently. So if you have any questions that we are unable to address during today's session, we will follow up with you separately and try our best. Also, please note that today's slides will be shared in a follow-up email along with the webinar recording. I would now like to introduce our presenter today. We have Margaret Chandler, Azalea's Clinical Regulatory Consultant. With that, I'll go ahead and turn it over to you, Margaret.
Thanks everyone for being here, and thanks Ellen for all the behind the scenes stuff you do. We couldn't do it without you, so we appreciate that. And looks like this was a popular topic today. We haven't really had a webinar specifically for RHCs and FQHCs. So this was actually originally published, I think, back in March, and then they updated it on Monday. So I thought, well, it would be good to review and then get the updates in there. The new stuff. So we'll just jump right in, and like Ellen said, please send in your questions and we'll do our best to answer those. So what we're talking about are the 2020 performance year flexibilities. There's a new payment for telehealth services, and there are additional telehealth flexibilities, more things that you can bill for telehealth than just COVID testing. So that's good news. And then there's an exception to the productivity standards for RHC that I thought you would need. I wanted to make sure that you knew about. So we have several slides. We'll just move on through. First, what we're talking about, telehealth services, the way it's worded from CMS is that it's distant site telehealth services. And any healthcare practitioner can do this. It doesn't just have to be the doctor. And I think they say distant site because it doesn't have to be in your office. It could be from home or wherever you are. I included a link down here. I have links at the end, but some of them I just wanted you to know what link went with what topic. So I just went ahead and put them on that actual slide. So if you want to go and look at all of the telehealth services related to COVID-19, you can do that. So billing, how do you actually bill if you have a telehealth service? How do you bill for it? And that was the primary gist of this update from CMS. That's why I'm jumping right to billing. Usually that's a little bit down the road. There is a new HCPCS code that is required. It's G2025, and you have to use that specific code because it identifies that the service was provided via telehealth, and the payment is $92.03. That payment is just during the public health emergency. It may change after we get out of the emergency. Who knows what they'll do. So, but that's what it is for now. So that, that's always good to know when you're deciding whether or how much or who you want to offer these services to. So here are the dates. Originally, you could they published this telehealth details on March 6th and added the patient's home because prior to whoops, sorry about that. Let me get back here to present. Prior to this COVID public health emergency, you could not do telehealth with the patient from their home. They had to be somewhere else. So that was a big deal. But you could actually go all the way back to January 27th to bill for these services. So if you were doing telehealth before that, then, you know, highly recommend that you go back and bill for those. So next is these, they made a big point of saying that these are changes that were made due to the emergency. So they call them emergency changes in policy, which I'm thinking means that they were that they're temporary. And it looks that way by the way they broke it out by the date. So from January 27th to June 30th, all of your claims with the G2025 code and the CG modifier, you'll be paid at that $93 all-inclusive rate. The CS modifier was required. So if you had claims, telehealth claims, and you didn't have the G code or the CS modifier, I recommend that you refile those. If you did include the G code and the CS modifier, you will those claims will automatically be reprocessed as of last Friday, Thursday or Friday on the 1st at the 9203 rate. So if you build with the G code and the CS modifier, you're good to go. They'll just automatically pay you at that higher rate. If you didn't, then I really suggest you refile. So you don't have to resubmit. That's the good part. If you knew about those modifiers and codes before, then you don't really have to do anything. Now, starting July 1st, you need to continue to use the G code, the HCPCS G code 2025, but you should not be using the CG modifier. So that's really the only changes from July 1st for RHCs on the coding. Now, for FQHCs, same time frames, January 27th to June 30th, you will need to use 3 codes. You need to use the prospective payment system specific payment code, which is one of these 5 G codes. And then you'll need to use the HCPCS or the CPT code that describes the services furnished, and use the telehealth modifier 95. And then the third code that you have to bill is this G2025 with 2 modifiers, CG and CS. So I think CG is that it's preventive care. I'm sure your billers will know exactly what to use that for. CS, I believe, is a new code for cost sharing being waived. So that's you know, you might have to go back and fill those in, but it's the same as with RHCs. You'll be paid at the 9203 rate, and your claims will automatically be reprocessed as of July 1st. So it's possible that some of you may have already started to see some of the higher rate payments coming in, hitting your bank. And so if you used all these codes this way, then you don't have to resubmit for the payment adjustment. Now, all of this was published back in March, so hopefully you got the memo and all of this was done. The part that's new is this part about claims from July 1st forward. For those, for FQHCs, you're only required to submit the G2025 with the CS modifier. You should no longer be using the CG modifier. And the 95 modifier for telehealth can be used, but you don't have to. So it gets a little more straightforward after July 1st for you. More emergency changes for FQHCs. There are telehealth visits that are not considered qualified visits by CMS, and you were supposed to be holding those claims until July 1st and bill them with HCPCS code G2025 with or without the 95 modifier. So here again, if you've already submitted those, I'm not sure. I couldn't find anything that said you should resubmit or wait. The only information I could find is to contact your MAC. So I'm guessing that different MACs are handling that a little bit differently. So if you have telehealth visits that are not qualified and you didn't bill, go ahead and bill for those and get paid for those. Now, claims beginning July 1st for these non-qualified visits, you only have to submit the G2025. You are required to submit the CS modifier. The 95 telehealth modifier is optional. The link down here at the bottom is all of the telehealth codes. So that I think it has a lot of general information too. So that might be useful for you to go to. All right, so this cost sharing, this is the part that was brand new that just came out Monday. And what they're saying is that the cost sharing is waived for COVID-19 testing. So if you do COVID-19 testing, you do not have to collect a copay or co-insurance from your Medicare beneficiaries. Medicare will pay you, reimburse you for the full amount of the visits. And this is from March 18th forward. It did give an end date on that. I don't know why they won't line up all these dates, but whatever, you know, if they're going to pay us, we'll take it. And so, you know, of course, they'll be paid according to their reasonable costs for specific EM codes or services, and those services have to result in an order for or administration of a test and relate to the furnishing or administration of such test, or to the evaluation for purposes of determining the need for a test. So you'll need to decide how you're going to document that to back up your billing, and you know, I'm sure you have a process for that. Just remember, don't collect a co-insurance from your beneficiaries, and this applies to both RHCs and FQHCs. All right, so on claims using this cost sharing modifier, for these services where cost sharing is waived, and by cost sharing in this context, they're talking about not collecting the co-insurance from the patient. What you would need to do for that is just use the modifier in the service line, both RHCs and FQHCs. When you get the payment, your payment will include the co-insurance. So you'll get all of the monies from Medicare or your MAC, not part of it from the patient. Here again, any claims that have already been submitted will be reprocessed on July 1st for the increased rate. And I think it's quite a difference in the rate. I think it was like $13 or something, and now it's $92. So definitely worth some effort to make sure all of these get processed properly. And just another reminder, co-insurance should not be collected from beneficiaries if your cost sharing is waived. So one of our teasers, one of our bullets was that there are new flexibilities for, and this applies to the fee-for-service provider in the outpatient department of a hospital. So if you are providing services in a patient's home, so this is not telehealth now, this is just any of your providers going to a patient's home, that the patient needs to be registered or admitted to your outpatient department, and then it's billed as a home visit for an outpatient. So the part that applies during COVID public health emergency is that you can furnish any of your clinical staff services in the patient's home as a provider-based outpatient department. The patient, as I said, has to be registered as an outpatient and bill it as HOPD services. as if the service was provided in the hospital outpatient department. So you need to remember to append the PO modifier and the PN modifier as appropriate. Now, the other one that is kind of really specific to COVID, or it could be any disaster, but right now we're talking about COVID, is to apply the DR condition code as a modifier onto these claims. So I'd really love if you could, if folks would comment, send us a question or comment to how many people this would affect, how many people, attendees do we have that would provide home service. That would be helpful for us to understand what your needs are. Here again, there's a link out to the more detailed where I got this information from. So if you want to go out and read it in more specific details, please do so. All right, additional telehealth services and flexibilities. So this one is effective March 20th, and it's saying that you can bill for EM codes that are just audio telephone evaluation for whatever the reason or chief complaint. It doesn't matter, as long as you meet these requirements. So you wouldn't bill the EM codes, you would bill the HCPCS code of G2025. You have to spend at least 5 minutes on the telephone by the physician or other clinician that can report EM services. It has to be an established patient. You can't provide this service for a new patient and have Medicare pay for it. So they'll have to come in at least once. And if they have been provided an EM service in the last 7 days, or this telephone visit leads to an EM service within the next 24 hours, then you cannot bill that. So, it's kind of tricky how you handle those telephone calls, but I can definitely see a need for this. Once again, the link is down there to general information and all of the telehealth codes. This next one, this flexibility, is called an expansion of virtual communication services. So what they're talking about with virtual communication services is if not using a telephone or Facebook or whatever, but you're using a secure patient portal. If you have been providing those kind of visits since March 1st, or you are starting to provide those, you can bill for those. This applies to both RHCs and FQHCs. You must use the code, HCPCS code G0071. That's the code for virtual communication services, which means it's via a portal, patient portal. So you can use these and bill for these services with the same rules: is at least 5 minutes of telephone service to an existing patient that hasn't had a visit in the last 7 days, or it doesn't lead to a visit in the next 24 hours. So I'm sure that most of your patients pretty well and know whether a telephone call is going to lead to a visit or not. So those are the high points of this one, and the link is there again. Now, this is the last one, and this was also new on this past Monday when they reissued this. It was a Learning Matters. So the new exception is productivity standards. They use those to help determine the average cost per patient for Medicare reimbursement in RHCs. It applies to all of your credentialed providers, or your clinicians. They have to have a maximum number of visits that they're expected to furnish, and if they don't meet that maximum number, then it's considered that they're generating excessive cost. And so that affects how much you get paid per patient. So, but during COVID, for now, your MAC may be willing to grant you an exclusion or exception to these productivity standards because, people can't get in. It's not very much under your control how many patients you see right now. So, that's going to really help some people, and other people it's not really going to matter. I think it'll be one extreme or the other. But more so, this was the extent of what they published earlier this week, and they just said that further direction will be forthcoming from your MAC. So keep an eye out for information on that. If this is hitting you hard with the COVID, that you're not able to meet your minimum number of visits. I think that's about it. Here are other links. This first one is the main document that I used to get this information from, and then just other links: COVID frequently asked questions and fee-for-service response to the emergency. So just links that I thought might be useful. And that's all I have. Thank you so much for tuning in and listening. And what questions can I answer for you all?
All right, Margaret, thank you so much. We do have a few questions that have come through. First one is asking, so for COVID testing, how should we bill? MCR will not pay for 99211, correct? Is that correct?
I do not know. I will look that up.
Okay.
I'm glad to have that question because I wondered when I was going through, do I need to include this about testing? So I'll look that up and get back.
Okay, we can follow up on that one. Next question's asking, on the first slide, we stated that any healthcare provider, we stated that this was applying to any healthcare provider. Does this include RNs and LPNs?
Yes. I think I probably should have said credentialed provider. If they're able to bill through Medicare or CMS or your MAC, however you want to say it, then it does apply to them.
Okay, great. Did get a couple questions regarding the slides. So yes, just as a reminder, we will be sending out a copy of the slides today, as well as a recording of the webinar. We have a question. We use the CS modifier on all telehealth services, whether they are related to COVID or not. Is that correct?
So the CS modifier is saying that you did not collect coinsurance from your patient or the Medicare beneficiary, and that you're expecting to be paid for the full amount of the visit. So they're probably going to reject that and say, or not reject the whole claim, but just say, oh, we're not paying for the whole thing. We're just going to pay for the cost share portion, the CMS portion, and you'll have to collect the rest of it from your patient if you haven't already. So if you are collecting your coinsurance from your patients, you should not be billing the CS modifier, because that's saying that you did not collect. And if we need clarification on that, please just let us know.
Okay, great. We do have one of Azalea Health's partners, Mark Lynn, that is listening in as an attendee, and he did write in. His understanding is during the PHE, new patients may be seen via telehealth, including telephone-only visits. So thank you, Mark, for sharing that. And I'll have a couple more questions here regarding the billing. So how do we bill for AWV through telehealth? Do we use G2025?
That's another one that I'll have to get back to them on.
And then back to the CS modifier, it looks like we have just a little bit more questions around. So is the CS modifier only for COVID tests and admin?
Well, it's a new, it is a new modifier that I believe they'll be using for other things. In this particular conversation or documentation that I was reading, it was only for COVID testing, but I would highly recommend that you go out to the telehealth codes and check that, because I was focused just on this one document, and it didn't say this is only for COVID. So I will look that up, and of course you all will have the links, and you can look it up too. But I will verify that. That's a great question.
Great, thank you. Let's see. Previous to COVID-19, was the CG modifier for RHCs only and not FQHCs?
I believe so, but I will double check that because I didn't go pre-COVID. So
Okay. Yes, thank you.
I apologize. I'm not a coder or a biller. I'm more on the clinical side. That's why I don't know all these answers, but I'm happy to get answers for you.
Yes, thank you. And we do have some billing experts at Azalea that we could also look to for explanation on some of these questions. Another question here, can I provide telehealth services from my home?
Yes, you can. That was one of the new changes that just came out. So absolutely. And that applies to all credentialed staff, clinical staff. If you can bill, then you can provide that.
Great, thank you. Let's see. Looks like we've answered all of the current questions. So I'm just going to take a moment and share with the attendees. We'd love to hear from you as far as new topics that you would like for us to present on. If you have any specific areas that you continue to have some questions around, and maybe it is around the billing and the modifiers, we'd love for you to take a moment and submit those different topics or different categories that we could look at for our next upcoming webinars. So take a moment and submit those, and we will collect them, and hopefully we can help address some more questions for you all. And while we are allowing them some time to do that, Margaret, is there any additional items you'd like to mention or resources that you know are available to them for just looking at these different tools and modifiers throughout these changes?
Well, I see, my observation is that CMS is relying a lot heavily on the MACs to implement these things however each individual MAC chooses. So I have two thoughts about that. One is that just make sure you're subscribed to all the information you can get from your MAC so you don't miss something. The other is when you're discussing with your peers across the country, don't assume because their MAC is doing something one way that your MAC is doing it that way too. Double check and ask your MAC, are you doing it this way or some other way? Just don't make assumptions. Of course, almost all of this can be rebuilt or fixed, but who wants to do that? So those are my thoughts when you mentioned that, Ellen.
Great, thank you. And it looks like we are actually reaching the top of our time today, so we will go ahead and conclude today's webinar. Any questions that we need to follow up on, we will do so, and you can look to hear back from us soon via email. And I want to thank everyone for attending today's webinar. A special thank you to Margaret for presenting. As a reminder, the slides will be shared in a follow-up email later today, which will also include a link to the recording in case you want to review again or share with any of your peers. So on behalf of Azalea Health and our presenter, thank you for joining us, and I hope you have a great rest of your day. Thanks. Bye-bye.